Wonderful, thank you very much. It's lovely to, I feel a bit like a Tour de France rider in that I have a lead-out crew, because all those three talks we've had have really positioned me beautifully to leap forward. So I'm John Newton. I'm currently the Director of Public Health Analysis at the Office for Health Improvement and Disparities within the Department of Health and Social Care. So I am a civil servant. I'm not a very good civil servant. I'm not very good at not showing what I think. Anyway, moving on. So I also have another role. That's probably why they don't let me on the radio anymore, actually. I have another role. I'm part-time professor of public health at the University of Exeter, which is a very nice connection to have. The first thing to say is it's an absolute delight to be here. I think the conference is fantastic, so huge congratulations to the organisers. There's so much that we as a community can all learn from each other. I think this opportunity, there's so much good material. Just look at the programme. Real excitement, real opportunity. And I think all the speakers we've had already this morning have demonstrated the huge potential, but also the limited resources we have. So there's there's an opportunity cost problem here, isn't there? There's an allocation problem. How do we choose the most impactful work to do with the limited resources we have and with the data that we have? Anyway, we'll come back to that. But that, of course, is one of the reasons why we need a public health approach. I'm going to start with a bit of data collection. So can we have a show of hands just to see who you all are? So could you put your hands up if you work in the NHS? And that's a lot of hands. For those of you, anybody, hands up if you're working in local government or national government. Significant but small, much smaller number of hands. And anybody who's working in the university academic sector, right? And then in the private sector, some. And anybody else, because I'm curious to know who else is here. Right, okay, excellent, thank you. Do you mind saying where you're from if you're not in any of those? Social care provider, thank you. I should have. Yeah, so we've got some charity, voluntary sector, social care sector. Yeah, hands up. Yeah, okay, excellent. So thank you very much. So great group. So a heavy NHS majority there. So the task I've given myself is to explain why we need a strong public health intelligence function. Peter started out by saying how important the question is. I absolutely agree with that. Michael has demonstrated the need for a population approach, which is very much a public health approach. And you've just seen a lovely demonstration of public health intelligence function in action with the dashboard. I'm going to start with the NHS because I was really struck by the coverage of the NHS 75 last week. So alongside all the celebration of the achievements of the NHS, of course there was discussion about what we need to do to fix the problems in the NHS. And there was a really striking consensus of agreement. So we had a group of people talking on the Today programme: Claire Gerarda, John Bell, Lord Winston, none of them particularly known for their public health sympathies, so Claire perhaps as a general practitioner, and they came up with the three things that NHS needs to do: prevention, strengthen primary care, and improve the use of its existing data and intelligence. And there was absolute clarity about that. And Amanda Pritchard came on later, and she really didn't disagree with that. So there is a huge, I think, understanding that the sort of things that we do in health intelligence, more generally, but particularly, I think, in public health intelligence, are absolutely relevant to what the NHS needs at the moment. This slide illustrates what people are calling the public health approach. There isn't really a formal definition of the public health approach, but by default, people have started to refer to it. And the point to make here is that the public health approach is absolutely not the preserve of public health people. It's being adopted very widely by groups such as the police, for example, on, this is an example from modern slavery, but drug abuse, all kinds of sexual violence and so on, all kinds of things are being addressed with the public health approach. And the fundamentals are, I think, fairly non-controversial. You start by taking a population approach. You collect data, you have evidence, but you also have descriptive data to understand the scale of the problem, the distribution of the problem. You work on prevention, You work in a multi-agency partnership way because you realize that almost all current problems are complex, complicated. No single body can address them on their own. For example, the hospitals need to look at what's going on outside the hospital just as much as they do within the hospital. And finally, you have to address social justice, inequalities, and human rights. Otherwise, it all becomes rather meaningless. So I think it's a really good summary of what the public health approach is. And so if you're going to take that approach has always been a data-driven approach, going back to Florence Nightingale, who described it beautifully, but it still is absolutely a data-driven approach. So what I'm going to do with the talk is just say a little bit about what we do in the Office for Health Improvement and Disparities, in particular in the Public Health Analysis Unit. And I should say, pay tribute to quite a number of my staff are here, people here from the Office for Health Improvement and Disparities, and please do come and meet us afterwards, come to the presentations and so on. I'm extremely proud of what we do in OHID. There are 3 functions of OHID, and I fully admit that we haven't been very good about communicating what we do in OHID. In fact, the arrangements for public health at the moment, I think it could be said, are complicated, more complicated than they were in the past. And it is one example of the famous saying that if you're not confused, you're probably not keeping up. So it is a bit complicated. But OHID has 3 pretty fundamental functions. Firstly, we drive policy in government on the wider public health system. We have this objective of increasing healthy life expectancy and reducing inequalities. And this was the point of moving the Public Health England functions into the department, was to put them closer to policy and integrate really the Department of Health public health functions with Public Health England's public health functions. And there's some quite good evidence that that's working, for example, around tobacco control. We have much more direct input into policy. So that's the first one, policy. The second one is to deliver some national programs which improve public health and reduce disparities. And there are quite a few of those. These are familiar to you. There's some of them perhaps more familiar than others, but things like the work we do on drug services, on cardiovascular disease prevention, tobacco control, water fluoridation. We run specialist committees like SACN on nutrition. There's an interesting report about to come out on SACN about ultra-processed food. All these are supported by staff in OHID, and we're just sort of carrying on doing all these things in the background that we used to do in PHE, we now do in OHID. And then the third one is the outward-facing function. We are there to support what other people do in the NHS, in local government, and in other areas. And specifically included in that is developing the public health workforce, including the analytical workforce, and this other bullet point at the bottom, surveillance and monitoring of the population health. It's a short term, it's a very big task. And that obviously takes up a lot of our effort. And it's probably worth pointing out that there isn't really anybody else doing that. I mean, surveillance of population health, you might think, oh, perhaps ONS does that. But actually they don't. They publish statistics, which, and we can discuss this, is a very different thing from surveillance and monitoring health. ONS, of course, do an awful lot of work, and actually we could mention, talking about the enormous impact that the dashboard made during the COVID pandemic. The ONS survey was another really phenomenal thing that we should be proud of as a community. So, what do we do in the Public Health Analysis Unit? Well, so we are almost entirely people who've come either from Public Health England or recruited since. And we are based, as I said, in the Department of Health. Currently about 150 staff, number of different professional backgrounds, which represent really the different stages of the value chain of using data and reporting statistics and producing outputs. We report directly into Chris Whitty, the CMO, so we are slightly different from the rest of OHID. So I report as the director direct to Chris, and that gives us a level of independence, which is slightly different from the rest of OHID. And Chris is very supportive of what we do. He is very involved and engaged in our work. And finally, of course, we work alongside other public health professionals in both the national and the regional team. So there is OHID has, as you probably know, regional presence as well as a national presence. So just the rest of the talk really is about describing a little bit about what we do, general principles, but also just show you some examples. and then I'm going to finish with a few looks forward to the sort of things we might do in the future. This is a word cloud approach. We have people doing data science, people like Purya. Purya no longer works for us, but we're still we have some great data science contributions. But at the same time, we also have people who work at the other end of the chain, thinking about how we deliver results to people, understanding what the questions are out there, so the knowledge translation. We don't do, one or two things not on there, we don't do health economics, that's in a slightly different part of the forest, and we don't do disease registration anymore. The disease registration teams moved to NHS England, but we still work very closely with our colleagues in those different areas. This is a value chain approach. We have Michael Heisman does some lovely infographics for us, this demonstrates the value chain. So it is a chain. You do start with data, you could say, and then you move forward. You manage the data, you manipulate the data, you enhance it, you integrate different forms of data and knowledge and evidence into insight and learning, and then in some way you use that. But the most important part about this graphic is that there's a feedback loop. There's continual feedback from the right-hand, from the right-hand side back to the left-hand side, so that the people who are involved in the value chain have a really deep understanding of how people are using the data, what the priorities are, and how to make sure that they answer the right question and that the work is useful. And that's my point really about the opportunity cost. It's, you can provide all kinds of useful outputs, but they may not be the most useful outputs at the moment. Of course, we're known by our products and our tools, of which there are many. Some of these, of course, are things which we produced under Public Health England, and we still continue to produce them. But there is, just to reassure you, there are quite a few new things coming out. We're continuing to develop. We are continuing to enhance the older products, and we have a fairly significant program of modernization of the tools and products that are coming out. We have, well, I'll talk more about those later, but we produce, for example, over 100 official statistics each year from within the Department of Health. Before we came in, the Department of Health produced one official statistics a year, which was the abortion statistics. Now we produce about 100. Fingertips is probably the one that people know best. Julian Flowers, I believe, came up with this term. The idea was to put the data you needed at your fingertips. It's become a very comprehensive tool which provides input into lots of indicator sets. And it essentially allows you to compare local areas in all kinds of different ways. And it's very, very widely used, particularly in local government, which is really where it was aimed originally. This is the health profile for England. So within Fingertips, we have the health profiles, which were generated some 15 years ago, which for local authority. But the health profile for England takes an overview of the whole country. We realized that a lot of what we did was essentially comparing local areas, but we weren't taking a national overview. And when we produced the health profile, we thought, well, this is just sort of tidying up. We thought it was just sort of filling a little gap. But actually, there was huge interest in it, because again, nobody else seemed to be quite doing this, bringing together data on risk factors, on ill health, on mortality, and describing and interpreting how they all fit together and what the meaning of it might be at national level, at England level. Excess mortality. So Michael mentioned excess mortality. This is it's an interesting concept because, of course, excess mortality has been measured for some time in health protection, looking at the effect of heat waves or flu pandemics, but it's not really been applied in the same way to general mortality surveillance. And we stood up a Power BI tool to report excess mortality for England in response to a request which came through in April 2020, and we were publishing this by July 2020. We had it available before then, actually, but it took a while to get it published. Excess mortality, for anybody it clearly shows an interesting pattern. The difficulty, of course, is trying to come up with an estimate of the expected mortality. You can count the number of deaths fairly easily every week, but the trick is to understand what you would be expecting, and therefore to create the excess mortality. Now, it was not too difficult during the pandemic because we were looking at the period before the pandemic and there was a fairly well-established trend. It's now become much more difficult because you have to allow for the fact that a lot of people have died during the pandemic. And so there's a real debate, which we're engaged in, as to how you should estimate excess mortality. But that's probably a whole other lecture. But it's an important example of a live tool that we produced and have been developing. And also, our excess mortality goes beyond what ONS does. It looks at regional level, it looks at inequalities, it looks at age, and it looks at cause as well. So it's quite a lot more sophisticated than the ONS data that's produced every week. The dashboard I've mentioned, I think, or you've heard a lot about the dashboard. It's a great tool. The thing I would say is that what struck me, the reason the dashboard was so successful was that it brought together really talented people who are statisticians and epidemiologists, really talented people who are digital, who understood user journeys, and really talented people who are engineers, people like Puria, who knew how to build this thing to do it. And it was these three different domains of knowledge and expertise that came together, which made it successful. It really was important at the time, because the data were coming out daily, and we knew that the politicians were looking at the data, the public were looking at the data, the professionals, everyone was looking at the same data at the same time, and it really did help improve decision making. As I say, to show you that we're still actually producing new work. This is a report on the drivers of healthy life expectancy, unpacking the contribution of self-reported health and mortality to healthy life expectancy, and trying to illustrate, if you are going to improve it, the sort of things you need to do. I've just mentioned the Global Burden of Disease study, which is a huge international modeling exercise run from the University of Washington, funded by Gates, looks at everything everywhere, but does provide some really useful data, comparative, looking at population attributable risks largely. And it's really it's a tool for rational priority setting. Absolutely, I mean, again, there's a whole other lecture about global burden of disease, but it's heavily used both nationally and locally. It's a collaboration with scientists, so this really just illustrates the fact that we work closely with academic colleagues and we publish papers in high-impact journals, and we continue to do that. We're preparing a paper on excess mortality. Moving on, so lots of products, lots of data manipulation, knowledge to action. The implementation of all this in the real world is absolutely central to what we do. In fact, we sort of start from there, I would argue. We start from what are the problems for which we could help, and work back to think what products should we produce. And this is an active process. And the thing that I want to stress, I mean, there are people here who actually would talk to you much more authoritatively than I can about the Knowledge to Action program. But the thing I would stress is that there is good research evidence on what works here. You know, we are evidence-based. We should use the evidence on how to use data and knowledge to affect change. And we often don't. We just assume we publish good stuff, it's up to other people to use it. And we cannot take that for granted. On the workforce, I mentioned that's a significant role for us, and it's one that we hold very dear. We're particularly pleased with the apprentice program. So during the pandemic, again, there was a clear need for additional capacity and capability. Somebody spotted themselves in the photo. Are any of the apprentices here, actually? Anybody who was an apprentice here? No? Oh, that's it. Yes, there we go. Right, thank you, thank you. There was a clear need for additional capacity and capability during the pandemic, and obviously we were able to recruit some people from the existing workforce, but it was obvious that we needed to bring more staff in, and we ran this program jointly between us in the LKIS function within what is now OHID, was then Public Health England, and the UK HSA. 42 trainees, and it's been huge. I mean, from our point of view, it's been hugely successful. The trainees were fantastic. It was very competitive. They came in with lots of skills. They developed very quickly, and they did really good work. You know, so it was a win-win. And they've gone on to find excellent roles in the system. Not necessarily with us. Some of them are with us, but many of them working in other organisations. So it was a great scheme, and we really would like to do something similar again. Right, that's a description of OHID. I think I'm okay just about. I've got 5 minutes to whip through the rest. This is a sort of reflection back. Can you come up with a general model of health intelligence? What do you need for a good, well-founded health intelligence system? This was a slide that I produced for the National Information Board, which existed between, I think, 2014 and 2017. Rather missed the National Information Board. It was a forum to bring together all the NHS bodies to come up with a strategic view of what the requirement was for information, data, and intelligence. And it was, I think it did rather a good job. Anyway, what you need for an intelligence system, you need these 4 boxes, and you need activity and success in all of them. So you need your data. So you heard from Ben yesterday about all those data issues, and I think really good work there on having a much better understanding of how we develop and manage our data, make it accessible, and so on. You then, moving up, you need tools, and you need ways of turning those data into meaningful statistics and outputs and so on. And a lot of, we've done well with that. So the dashboard, for example, but that's just one example, a whole other areas where we need tools and outputs. And then the workforce, of course, we need to develop the workforce in terms of supply. We need to train people, but also we need to persuade organizations to provide good quality jobs and careers and do a workforce planning for the health intelligence workforce. And then in the box on the top right is perhaps the less obvious one. We need to make sure that the organizations and structures have the right mandate, so that the top of the office really needs to design the organizations correctly so that they do use data and give enough significance and importance to data. So there we go. I commend that to you, the 4-box model of a health intelligence system. And the point about it is it's a system. People move around, doesn't really matter as long as you can contribute in different ways. There should be very porous boundaries there. Right, that's sort of that's the boring bit done, not the boring bit. I was just going to show you a few slides of data, because I know you all like data, you all like seeing fun data. So these are just a few random methodological thoughts, and then I'll finish. One of the things and this is from Julian Flowers, when we produce profiles, we have loads of indicators. Became obvious when you do, a lot of them are very strongly correlated. So actually you wonder, well, do we need to report all these indicators? And in fact, we found that the 3 that really determine, these are local authorities, the 3 that really determined what your results were deprivation, whether you were urban or rural, or whether you were London or not London. And if you knew those 3 things, you could largely predict an awful lot of the rest. So that was just really to stimulate thoughts about whether we could be a bit more efficient. This is just a bit of classic epidemiology. And my background is I'm a public health epidemiologist. Worked actually with Ben Goldacre's father, Michael Goldacre, for a long time in Oxford on the Oxford Regular Income Study. Age period cohort approach. There's the director of the West Midlands Public Health Observatory, John Kem, did this some time ago, I think probably about 11, 12 years ago. He looked at smoking by age, period, and cohort. And you get some really interesting, this has been updated in an academic paper. You get a really interesting picture here, and I think we should remember this approach. And what it shows is that essentially all the lines slope down to the right, because people start to smoke up to the age of about 21, and then from then on, you're trying to get them to stop. And the thing that really matters is pressing down on that peak. So if you can stop people, if you can keep that peak low and stop young people starting to smoke, you can then get the rest to stop. And that's how you achieve smoke-free. And it's just showing the data like this really illustrates that beautifully. And there are probably some lessons from this approach in the pandemic, because the point about the pandemic is it's a period effect. Now, I have to show this one because it's about waiting lists. So Michael pointed out that we don't know very much about waiting lists. I've been trying to do this for the last 20 years. This is a 20-year-old picture showing that you can analyze waiting lists using survival analysis. So you can apply Cox proportional hazards approaches to waiting lists. And you get some lovely, you can adjust for case mix, you can adjust for age, you can adjust for ethnicity, etc. And you can even put confidence intervals on it. So there's a huge amount we could do, completely agree, a huge amount we could do to put more intelligence around the waiting list data, if only we could get at it. And then this is just the power of modeling. I notice there are a number of modeling papers. We have imperfect data, we have incomplete data, but we can do better than that because we can fill in the gaps. I think there's a huge amount we could do to use modeling. And in fact, sometimes we don't realize the modeling is going on. A lot of the results of the ONS survey were actually modeled. You'd think, well, you just measure it. A lot of it was modeled. Right, I've finished. Conclusions. We have a very strong track record of public health intelligence in the UK, actually, but particularly in England. We have huge potential to contribute to the current priorities of the NHS, but also the system as a whole. We need to challenge ourselves to innovate and develop. You know, yes, we've done some great work, but we really need to do things differently. We've got new problems, new people, new organizations. We've got to be agile, as Perrier says. We've got to listen, we've got to get out there. And we have to work as a system. So we can't be precious about different organizations. We have a strong history of being reorganized, so it wouldn't surprise me if we get reorganized again. So we have to be resilient to reorganization, and we have to cherish the workforce. So I'll finish on that. We have to cherish the workforce. Thank you.